intro. I've tried to do this like intro a million times. I'm just so awkward. I'm here to talk about labor. I don't really know what I'm doing. I just have like a document on my computer and it's just like listing things I want to talk about. I also have this whiteboard, but I'll try to make this as short as possible. The main thing I wanted to go over is just like what is happening to your body during labor. Like what is labor? What's happening? First, like little anatomy, so we're on the same page. Okay. Okay. I'm trying to draw the labia, okay? Here's like the clit. Okay. Okay. So here's the labia on the outside. Here's your vagina. And then it's leading to your cervix. Oh, this is horrible. I hate this already. Maybe I'll just insert pictures. So the cervix is the barrier between the vagina and the uterus. You probably already know this, but I'll just review. And so that's what is keeping your baby in place during your whole pregnancy. And now when you go into labor, we need the gates to open up. We need your cervix to open up, or dilate is what we call it. We also need your cervix to thin, which we call effacement. And then we also need your baby to lower down into your pelvis. And that is called station. Like what station is your baby? In terms of dilation, it goes from closed to 10 centimeters. For effacement, it's pretty much like thick to 100% effacement. And then for station, it goes from like 4 all the way to +3 +4 is pretty much crowning. So minus numbers are when your baby's high and plus numbers are when your baby's low, and that's where we want to get to.
So when your nurse or midwife is talking about where you're at, they're going to say, okay, you are 290 and -1. And so all those values are the things we just talked about. So that first number, 2, is how many centimeters dilated you are. Then that second number, 90 or 90%, is the effacement, how thin your cervix is. And that last number is the station, -1. So that is where your baby's head is at. You'll hear them say these values a
So
lot, and
how we
I think it's
determine these things
helpful
are
for
by
you to know
cervical
exactly what all those
exams.
numbers mean.
And that would be your nurse or your midwife, putting our fingers into your vagina. And we're basically reaching for your cervix, and then we're seeing if, okay, can we only fit 1 finger, 2, and then how much are we able to move our fingers apart? That would be determining your dilation. You can feel how thick it is too, based on like how much of our finger is going in. And then we're feeling for where is baby's head in relation to your pelvis. So yeah, unfortunately, that is the only way to find out how dilated you are, is through a cervical exam. And when you don't have an epidural, they're pretty uncomfortable. I don't know if you've ever tried to like feel your cervix before, but it's, it starts pretty far back and it can be hard to reach. So they're pretty uncomfortable. I would recommend, if you ever get a cervical exam, to put your fists under your hips. It helps like move your pelvis forward in a way that's easier for them to check your cervix. And just try like as hard as you can to just like relax as much as you can. I've done cervical exams on people that are like really tense, and it like almost hurts my fingers, and it makes it even more difficult to feel where the cervix is. So if you can try to like relax and put your fists under your hips, it might make the whole thing a lot easier and faster. So how does your cervix dilate? It dilates from the contractions, the uterine contractions. And what is causing those contractions is a hormone called oxytocin. It is it runs this positive feedback loop. So it just keeps adding and adding more to it, more to it, more to it. And then causing your contractions to be stronger and more frequent. And all those contractions are helping push your baby down, and it's helping open up your cervix.
This is your uterus and this is your baby. Here's your cervix, which would feel like the tip of your nose. Now with practice contractions, aka Braxton Hicks, uterus is contracting with no changes to your cervix. However, Braxton Hicks contractions help tone and prepare your cervix for real labor contractions, as you see here. Now, real labor contractions pull up on the muscles and fibers of your uterus, making the fundus thick. The thick fundus helps apply more pressure. This helps your cervix become softer and shorter, like you see here. This is also where dilation begins. And at this stage, your cervix feels like your earlobe. There's more dilation, and as you continue to contract, you get closer and closer to your baby until, there you go.
Yeah, that is pretty much the mechanism. Oxytocin causes contractions, which then help push your baby down and cause your cervix to dilate. So that's pretty much it. And then after that, you push. And that's, in the simplest form, that is what is happening. So a big recommendation I would give to you is that if you go into labor on your own, try to labor at home for as long as you can. A lot of first-time moms, start having contractions and then they become regular and then they're like, oh shit, we need to go to the hospital right now. But the thing is, with first babies, they usually take a long time. It happens where people are in labor for like a day, 2 days. It happens. Versus like second, third babies, like the mom could start having contractions and then have a baby 4 hours later. So my recommendation for you is if you do go into labor on your own, just try to stay at home. That's where you're most comfortable and where you can best relax. You can go in the shower, you can lay on your couch. It's just a much more comfortable environment than the hospital, where when you get there, we're gonna be asking you a bunch of questions, admitting you, placing an IV, putting the baby on the monitor. There's just a lot going on. So I would wait until your contractions are getting oof, okay, maybe I'm gonna want an epidural in the next hour or so. Then I would go. But you can also, at least this is how this works at my hospital, moms are able to call us and get our opinion for what we think. So keep in mind, this is also just for contractions. If your water breaks or anything, if you start having abnormal bleeding or anything like that, definitely go to the hospital. But this is just for just the contractions that you're feeling at home. Monitor them, time them, see how long they are. Yeah. Also, by the way, majority of the time, it is not like the movies where your water breaks and then you go into labor. It could happen, but majority of the time it doesn't. Sometimes the bag of water doesn't even break on its own and the midwife will have to break it. Other times too, your water breaks and then you don't go into labor. I literally had a patient last week who her water broke and then she didn't come into the hospital and she waited 10 hours and nothing happened, and then she had to come into the hospital to be induced. It's not, majority of the time, it's not like the movies. So what happens in that scenario then? If your water breaks and you don't go into labor, or if you go into labor on your own and it stalls out and they keep checking your cervix and you're not making any change, your cervix is still staying the same. Or if you show up for a scheduled induction, then what we can do is give you medications to help progress your labor / put you into labor. And the most common medication that you will probably get regardless is called oxytocin. And that's literally the hormone that your body makes to cause those uterine contractions, make them stronger, make them more frequent. We can give that in an exogenous form through your IV. There's another medication, it's a little pill, it's called misoprostol, and that helps soften your cervix and make it easy to thin out and dilate. That we only give for patients that their cervix is closed or 2 centimeters, really early on is when we give it. that's all we have at my hospital. Some hospitals have Cervidil, I think it's called, but I don't really know much about that and we don't use it. So some other things are, if your water hasn't broken on its own yet, the midwife breaking your bag of water can actually help progress labor. It releases hormones pretty much to help your labor along. Also, what they can do is they can put a balloon in, like, through your cervix. It's really uncomfortable and I really hope this doesn't happen to you, but it's called a Foley balloon. There's also a Cook's balloon as well, but this is like mechanical dilation. Like, this is literally like putting so much pressure against your cervix that it's like making it open up. So those are the things that we can do to induce your labor / augment your labor. And augmenting means like just helping it along in case your labor stalls out. Next, I want to talk about the epidural and what to expect for that. Basically the epidural is kind of like an IV that goes into the epidural space in your back. It's, like I said, it's like an IV. It's continuously running medication through there, and the medication is fentanyl, which not a lot of people know, and they see fentanyl and like get really scared, but it doesn't pass the like placental barrier or whatever, so it won't affect your baby. And so what you do for it basically is like, you're gonna like sit in this curved position and the anesthesiologist is going to feel your back and then they're gonna numb your back, and that's literally the worst part, is just them numbing it. And it's a lidocaine shot, which is the same kind of shot as like when you have cavities and they're doing like fillings and stuff. It's that same like really stingy medication, but that's the worst part. And then after that it should be fine. My hospital has great anesthesiologists and it usually only takes like 10 minutes. We had like a really shitty anesthesiologist for a while and he took like an hour one time. So I don't know if that's normal at other hospitals, but for ours it's usually like really quick. Okay, so important. When you're at the hospital, the nurses are going to be monitoring your baby's heart rate, and then there's going to be another monitor for your contractions. And this is literally like the biggest part of our job, is just watching the monitor, because it's telling us how your baby is doing on the inside, your baby's well-being. If your baby's heart rate drops, that is what we call a deceleration or a decel. That is indicating that your baby is not getting blood flow, not doing great in there. And there's different kinds of these decelerations and they all mean something different. So one of them can be because the umbilical cord is getting squeezed, like with the contractions, it's squeezing it. Or if your baby's like literally like laying on the umbilical cord or squeezing it or whatever. So what we'll do in that case is like your nurse will come in and have you change positions. And if she does that, like try to be quick about it, because I've had patients like take their sweet time and I'm like, no, like your baby's heart rate is down, like we need to go a little faster. So yeah, I just want you to be prepared for that. So if your baby's heart rate goes down and it stays down and it's not coming up, that would be like emergency C-section time, which is rare. So that is how we would determine like, okay, emergency C-section time. I just want to mention this because, you know, it happens and I want you to be prepared for that. So that's a big thing, is like for us nurses, is like making sure your baby is doing okay and is handling all those contractions, all that squeezing. And obviously there's like a lot of more interventions we can do, but I feel like it's not important to get into, but I feel like for you, like the changing position thing is important. Pushing, well, we don't have to talk about pushing, but I want you to know that first time moms can push like up to like 2 hours. And it's a lot of hard work. Like, it is genuinely a workout, and they don't call it labor for nothing. Like, it is hard work.
Bring your legs back.
Yeah, relax.
You're
That's
gonna-
what I'm saying. When
yeah.
you feel that resistance, like here, like you want to
You're
push
pushing.
us.
You're pushing this.
So you
want
look,
to push
yeah.
back.
So you should
Just
lean
let.
into it.
Good, more. Yes.
Go, 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 go.
Beautiful.
Breathe and do it again. Big, same one.
2,
Hold it. Long, long, long. Go, go, go.
5, 6, 7, 8, 9, 10.
I guess just like after you have your baby, as long as everything's okay, they'll put your baby on your chest. They're like wiping down your baby, and you might think like, why are we wiping the baby? Well, one, they can get cold really fast, and it is like horrible for them. They're just like, they need so much help. So they need to be wiped down because you don't want them to be wet and cold. You want them to be warm. It also helps make them cry, and you actually like want them to cry a lot when they first come out because they're clearing their lungs and getting rid of all that amniotic fluid that's in there. It's also normal too for your baby to come out like looking a little blue. It's normal. Also, I feel like this is really important for me to tell you because I'm trying to be as realistic as possible, but I'm not trying to scare you. The epidural is not always 100% effective. Sometimes it's one-sided where you only feel it on one side, and the other side you're feeling all the pain. It just depends on like how well they place the epidural. It can be like your own anatomy. If you've had the epidural for like multiple days, it can kind of like wear off. The anesthesiologist can replace your epidural, but I just wanted to mention like it is not a guaranteed pain-free labor. It is still possible that you can experience some pain. I just want you to be prepared for that. I feel like majority of the time they do work, and they work well, and there's only like maybe mild to moderate discomfort, but I've seen it happen where like the epidural just like isn't working, and it's a horrible thing to see, and I can't even imagine how that feels, but I need to tell you that. Also, I'm not gonna get into like anything super scary, by the way, but it is very normal for you to have a laceration when your baby comes out. So, you know, so many people are like, I don't want to tear, but you're like almost guaranteed a tear. I mean, a whole freaking baby is coming out of your vagina for the first time. Majority of the time, they're not bad tears at all, and they're very easily repairable. It's very normal for you to tear. There are some things that you can do to prevent tearing. Perineal massages, you can look that up. Or while you're pushing, you can keep like a hot cloth down in your perineum area. And your nurse should be doing that for you. That's what I like to do with my patients, is like put a like warm cloth there. Some other things like you need to be aware of what can happen is your baby can poop while she's still inside you. That poop is called meconium. I don't know if you've ever seen it. I'll put pictures here, but babies' first poops are like black tar, and if they poop inside, they can swallow it and it can get all in their lungs. So it's not great. It's not like an emergency. It happens. At your delivery, the NICU will probably be there just to like suction out all of that gunk. Okay, some other random things too to think about is if you want your baby to get all the standard baby medications, that includes a vitamin K shot, a hepatitis B shot, and erythromycin eye ointment. The only one that is like a necessity is the vitamin K shot. It will prevent them from like internally bleeding. I don't know, we have like phases where people will get these like people that will refuse the vitamin K, and it literally like makes me so sad. I'm like, why? I think people just genuinely aren't educated on it, but it is a lifesaver. Obviously, all three of them I recommend, but if I had to recommend one the most, and I would say is a necessity, is the vitamin K shot. You can also think about if you want her to get a bath or not at the hospital. At my hospital, we don't give baths until the baby's at least 12 hours old. They come out with like this cheesy stuff on them. It's called Vernix, and it's actually really good for their skin. So it's good to let it like sink into their skin. I feel like this is getting way too long, but I'm just gonna like speed run through some things. Delayed cord clamping, look into it. It's standard at my hospital. I don't know about your hospital, but it's very beneficial. Try to breastfeed as early as you can. And I can get into a whole thing about breastfeeding too. I might think about like becoming a lactation consultant one day because I love breastfeeding and helping people well, I don't like breastfeeding, but I like helping people breastfeed. Also, after you give birth, your nurses are going to be pressing on your stomach, on your uterus, and it doesn't feel great, but they're preventing you from hemorrhaging. That is why they're doing that. Try to sleep when your baby sleeps. Oh my gosh, try to get as much sleep as you possibly can, please. Even during labor, if you're able to sleep, please sleep. Also, I would recommend if you wanted to have like your mom and dad come to the hospital, like have them come. This is totally your decision, by the way, but in the first couple hours after you deliver, like that's when you can hemorrhage, and that's when we're like doing a lot. We're like constantly looking in between your legs, like pressing on your tummy, like looking at the bleeding. That's when you want to start breastfeeding. So there's just like a lot out, but again, it's totally up to you and it's your delivery. I also want to mention any intervention, anything that the midwife or nurse is like trying to do, you can always say no, and you can always think about it. If they tell you like you can't eat, like you can do anything you want. You can literally walk out the hospital. Like it's not a jail and you're not forced to do anything, but it is probably in your best interest to listen to them at least. I just want you to know, like before anyone does anything, like you have the ability to say like, no, can I think about this? Because there are some things that happen that I definitely like don't agree with. Okay, say little baby's crying and you're like, I don't know what to do. Like she just keeps crying. It's okay. Just go through the list of things. Number 1, is she hungry? Number 2, does she need a diaper change? Number 3, is she gassy? Do you need to burp her or help her fart? Number 4, is she too hot? You can tell this usually because she'll be like sweaty around her neck. You want to make sure she's not too hot, and you want to make sure she's not too cold. And it's hard to tell visually if a baby's too cold. They will like, she'll do this like shaking thing when she's a newborn, because that's her like immature neurological system. A lot of parents are like, they see the baby shake and they're like, oh, here she's cold. But it's actually like, no, they don't have that shivering mechanism as a newborn yet. It's just their neurological system. So just make sure she's like bundled and warm. Or if it's none of those things, then sometimes she maybe just wants to be held. It's like, it's hard for these babies sometimes to make the transition from like being inside of you and being warm and all like snuggled up and hearing your heartbeat and hearing the sounds inside to going to this like really bright, cold world. So some things that have helped: warm baby blankets and like swaddling them real tight and real well. I saw you had a sound machine on your registry. That's really great too. Like babies do really well with the sound machine. And also too, when you're trying to sleep, I think the sound machine is great too, because at least at my hospital, the walls are so thin and you can hear people outside in the hallways. Oh my gosh, I don't really know what else to talk about, but if you have any more questions or anything I didn't cover, or I don't know, literally anything else, please like don't hesitate to ask me. I'm so excited. Holy shit. Like I can't wait. I'm so excited for you and I can't wait to meet her. And I don't know, I just feel like time is flying. I hope this was helpful, and I'm sure your class, like actual classes, will go over more of this stuff in depth, but I just wanted to cover like the main things that if I didn't know anything that like I would want to know and be prepared for. So yeah. All right, I love you. Bye.